Okay, I think we got it working again. I apologize, we had some internet connection issues. So we're going to try to continue where we left off there. Okay, I believe we were just talking about the jaw thrust for a trauma patient in opening the airway. You should be able to see that actually pretty good there. You can see the chin come up, and actually the airway will move a little bit there. Okay, so we're not manipulating the neck, and we're opening the airway. If no trauma is suspected, then we can do what's called a head tilt chin lift. So our patient is lying here on spinal support apnea, and what I like to do is I take one hand underneath the base of his head, right in the back of the neck there, and other on the forehead. I'm going to push down here, and I'm going to lift up underneath the X slightly. You see they go into what's called a sniffing position. If you were to sniff just like that, you have your head up a little bit. That's what we're going to do right here. You don't want to hyperextend, because that can actually not work as well, end up closing it off again. But you just want that slight sniffing position just like that, and that's the head tilt chin lift. Okay? So we've got it open, and now we're going to use an OPA, which is truly unresponsive, no painful stimuli there. We rubbed on the chest, the sternal rub, nothing's going on. So we're going to try and insert an OPA. We need to measure it first, make sure we got the right one. What we want to do on this patient is we want to, the top here, the flat edge there, we'll put that in the corner of the mouth, and we want the bottom to be around the earlobe, and that's exactly where we are right there. So this is going to be the one we go with. When we insert, we're going to open the airway. The mouth may be closed on this patient. You do what's called scissor technique. If it is, scissor technique is you take your pointer and your thumb, and you actually just slide them apart just like that, and you'll create a scissor-like technique, if you can see that. And you just put, if you're on this side, my thumb is on the lower teeth and my pointer's on the upper teeth, and they're just going to scissor away, and it's going to help open up that airway. Having someone to help you with opening the airway manually at all times is really going to benefit the patient in ventilations. So we're scissoring. We're going to point the OPA, the little curved tip is going to point up towards the top of the head. Okay, so we're going to insert that in, and that's going to be on the hard palate, right at the root, the hard part on the roof of your mouth. That's where it's at right there. And then when we get back to the soft, we're going to rotate down. And as we rotate, it should settle into place. That curvature that we talked about is actually holding that tongue up, right? It's preventing it from falling down with measures, so we know it's fitting good. Okay. Now let's say that this person did have a gag reflex, and we need to use an MPA. Now an MPA, the nasopharyngeal airway, like we talked about, that's going to go in through the nostril, through the nasal passageway, into the pharynx. And we need to make sure we use the right one here. One little method, some people say use the about the size of the patient's pinky diameter will be related to your MPA diameter of your tube. But measuring, you will set the trumpet end around the nostril and measure down, and you want that to come down to the earlobe. So this will fit pretty good right here. Excuse me. Also, anytime using an MPA, we want to use a good lubricant, and really, because this stuff can get a little bit rough if it's dry skin or something. If you don't lube that up and you go in, and you might not feel like you're forcing much, but it could really do some damage with some skin irritations, actually cause some bleeding. That blood is going to follow gravity. This person's laying down, so it's going to go back into the back of their airway there, and then you're looking at possible aspiration, and we'll have to break out the suction on that. But this bevel tip, if you can see that real close, I don't know if you can there or not, but there's a little end cut off of the end of this MPA, and that end right there, we're going to point that towards the middle of the nose, the septum, and that's pointed there. We've got it lubed, and it should go in nice and gentle. If you have to force this, then you may need to rethink your game plan. The last thing you want to do is cause some injury. Now, say any time during this process we have secretions or fluid in the mouth, we need to use our portable suction here. We have a hard catheter, a Yonker. There should be a valve on these. Some do not have them. If there is an airway valve, if your suction unit's on, like that, it's just a flip on. We're not going to cut it on for this purpose because I don't think you'll be able to hear me. But if there is a valve, you can leave this on and it will not really do any suction because it's sucking through all these the different valves and stuff. You go in, never go in past where you can see. You want to see the end of the tip at all times in the back of the mouth or the nose, wherever you may be suctioning, with every type of suction catheter you're using. But you, in the oropharynx, you don't want to go past what you can see. And you want to suction on the way out. So you get in, then you put your finger over that valve, suction. You want to keep it no longer than 10 to 15 seconds on this adult unconscious patient here, because you don't want to strip them of their oxygen that they already have in their lungs, in the air there. You're just going to deprive them. You keep sucking it out, and we don't want to do that. We want to get in there, suction when we need to, and then get out. If you're using a hard catheter that does not have a valve on it, it sucks continuously. If this is on, insert, then cut your machine on, and suction on the way out. Okay? So we've suctioned, we've cleared the airway out of that, and we've got our adjuncts in. We've got someone helping us to do a head tilt chin lift, like we talked about. Now we go on to our BVM. Our BVM, or bag valve mask, has actually a mask seal right here. If you can see that, it's actually like a raindrop type shape, if you can see it pretty good right there. The narrow portion will go over the nasal bridge, and then the wide portion will go over the chin area at the bottom. So the way we're going to seal this on a person, because some people are more difficult to create a good seal on. It's got this bubble, this air pocket down at the bottom, actually helps create a good seal on uneven surfaces. But if someone like myself who has some facial hair, or maybe dentures or some other reasons, you can't get a good seal, you really got to focus, might need a little bit more assistance. But on this patient, lucky for us, this guy's shaved up pretty good. So we're going to put the narrow end over the nasal passage, and we're going to do what's called a C&E technique. I'm going to make a C with my thumb and my pointer, and my other fingers are sticking straight up. So I got a C there, and then you can stick it sideways and get an E. Okay? And what that's going to do is C is going to go over the mask, and I have my thumb over the narrow end of the mask, and my pointer underneath the jaw, the chin of the patient. The E will be going down and actually forming. You can see this is the jaw line here, right through here, and I'm grabbing the jaw and pulling up. So I'm pressing down with my C, pulling up with my E, and that's creating me a good seal. And if I'm doing this accurately with a good open airway, I should see good chest rise and fall when I ventilate. You see the lungs moving really good right here, so that's really what we want to see. And that way we know we're oxygenating good. Once we start to ventilate, we want to keep it at a rate of 10 to 12 ventilations per second, so roughly every 12 seconds, or excuse me, every 5 seconds will give you 12 ventilations per minute. And that's what we want to keep at. As you're ventilating, you want to watch this patient for any changes, any blood pressure, vital signs, heart rate, O2 sats, the skin color, if that changes, and a big thing, your responsiveness. Is this person becoming more responsive now? If they do, the MPA normally does not cause any gag reflex. Maybe if you got one too big, sticking too far, it could stimulate the gag reflex. So normally you're pretty good with leaving that in. They may not like it if they come to and pull it out, but if it's not bothering them, then try to stay with that. The OPA, it will stimulate a gag reflex if they get back to the point where they do have that, so we do need to pull that out. What you want to do is encourage coughing, so cough for me, cough, 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 and then pull that out. Don't twist on the way out like we did on the way in, but just pull out like that. So that's the basic ways to control airway or help ventilate a patient using BVM and adjuncts. But I would like to talk to you about how I'm going to be grading how I would assess for this. And in doing so, excuse me, let me fix this a little bit. In doing that, what I would use and what I like to use is the National Registry for EMTs, their skill checkoff sheets. These actually have good point systems. They have critical criteria. The students get something they get their hands on and can really see exactly what they need to be doing. I advise them not to get in too structured of a format. It can actually, sometimes I've noticed that students will get a little bit frustrated or caught up and try to memorize things as opposed to what they have learned and what they know, and it stresses them out. So I try to get them to relax and study this paper, but forget about this piece of paper. But I like it. I think it's used good, especially afterwards. I've got notes here. I've got points. I can see what they did and what they didn't do. Help me recall everything a little bit better with them. But I like this system, and that's what I'll be using. If it does take a little while to do 25 students in a certain skill, but with good class time management, it should be doable. Thank you for your time. If I can do anything else to improve, just let me know. Thank you.